Our next speaker is Professor Dusty York. Dusty York is the immediate past president of the Society of Nuclear Medicine and Molecular Imaging Technologists section. She's associate professor and clinical coordinator of the Nuclear Medicine program in Chattanooga State Community College, located in Chattanooga, Tennessee. I must say that she was named the Society Outstanding Educator of the Year in 2017 and Augusta University Alumni of the Year in 2020.
Thank you. I actually had them mic me this morning because I typically podium, but I think that this one will actually work. So I am speaking on, for the Technologists, a historical and present day look at therapy. And I think when we think about this, we all are trying to figure out how we incorporate therapy into our departments and how we train our technologists. So this is something that we are continuing to look at. So when we look at a brief history, we can go all the way back to 1946 with that first atomic cocktail treatment. So that takes us all the way back to the beginning of nuclear medicine. After that, it was many years, actually about 67 years in the U.S., before we had the next agent that we could call a true therapy agent, and that was in 2013 with radium-223. Now, we did have some other agents along the way. Some of those have been successful, some of those have been removed from the market, and so forth. But these are the major ones that the United States has FDA approval for at this time. So in 2018, lutetium dotatate. You'll also notice that sometimes the U.S. is quite behind on some of these agents as far as FDA approval goes. And sometimes in Europe and in other countries, these agents are approved way before we actually have access to them because of this agency called the FDA. So it's quite restrictive in how you can get drugs passed. So in 2018, I-131 MIBG, which I hear this week is probably going to be removed from the market by Lantheus as far as production. They plan for that to be terminated early next year in the first quarter of 2024, which is quite disappointing, I think, when we have these agents that do come on the market and they show that they can be successful, and then we actually lose the ability to use them, sometimes due to cost, sometimes due to limited use, but it is also very unfortunate. And then in 2022, so last year, lutetium-177 PSMA. Now, when you go back to the history and that first treatment for cancer, you'll see that Samuel Siegling was actually given the credit for doing that first cancer treatment, and that came in the 1940s. But if you go further back and you look at the true history, you will see that Dr. Saul Hertz actually did the first treatment for hyperthyroidism with I-131. So in the 1930s, Dr. Hertz simply raised his hand in a meeting, probably something like this, and he asked a physicist, can we actually take and create man-made I-131 and make it radioactive? And the physicist at the podium simply could not answer his question. And he jotted it down on a piece of paper. And later, when he reviewed it and researched it and determined that yes, you could, he followed up with Dr. Hertz in a letter that stated what he had found and that this was truly a possibility. And that is the proof that Dr. Hertz is the father of theranostics. Now, you all have a special treat over in the exhibit hall. Dr. Hertz's daughter, Barbara, is here with a display and has all of the history of how this has taken place. It's very interesting, so you should definitely visit her booth over there and discuss that with her and see that. You'll also see there in that image to the right is his assistant, and she is termed as being the first technologist in the field of nuclear medicine because she did assist him in this process. Now, I know you can't actually read this, but I wanted to show you a timeline that goes from the 30s all the way to current day that has lots of other things that happened along the way. And at the bottom, actually, there it actually mentions the Netter trials. So there's several steps and things that have came on the market and removed from the market, especially like our monoclonal antibodies, and when we looked at that information. So those are jotted down through the history, but are not actually those main points that we just looked at. So what is the role of the nuclear medicine technologist in this realm of radiopharmaceutical therapy? That's what we're going to look at now, and I just briefly wanted to look at the education. So if you look at the education requirements here in South Africa, a lot of times those education requirements involve the technologist was a radiographer first, and then a nuclear medicine technologist. From my conversations here, I've also discovered that due to workforce pipeline issues along the way, some of those things were changed, and maybe some technologists are not actually radiographers, but are just nuclear medicine technologists. And you're thinking, well, our educational structure could be a little bit different depending on what path you took. If you look at the United States pathway, were far more difficult. We had to create a chart that tells you how to become a nuclear medicine technologist. So in the U.S., we have everything from the associate degree path to the bachelor's option, all the way to the master's level degree to become a nuclear medicine technologist. And it's very unfortunate that perhaps these three individuals that went associate, bachelor, and master's, if they're just a standard nuclear medicine technologist in a department, may not be paid any differently depending on their degree type. Now, it can open doors and opportunities, for example, to become a supervisor or a lead tech, or actually be over the whole radiology department per se. I've even had graduates go through my program who are now CEOs of institutions. So it does open doors, the higher level of education that you have, but we have a very broken system in the U.S. on how to become a technologist. So the role for you all here in South Africa, and this comes from your scope of practice, says patient preparation and assisting in the administration of therapeutic radiopharmaceuticals and adjunctive medications under the supervision of a nuclear medicine physician or radiation oncologist as part of standard procedures for treatment. So I took that right out of your scope of practice. In the U.S., ours is very similar. So we look at regulations with the Nuclear Regulatory Commission, and then our scope of practice actually states allows the NMT to perform and participate in all elements of theranostic care delivery. So that could really depend on how the process is going in your facility as to what the requirements of the technologist may or may not be. So ideally, when we look at this, it's a multidisciplinary approach. Okay, so it's not going to be one person performing these therapies. So typically that care team may be a medical or a radiation oncologist, a radiologist or a nuclear medicine physician, a technologist, perhaps even a pathologist, and a nurse. So it takes a team approach to be successful. And then we have to ask about adjunctive medications. Who does those? Who's in charge of these adjunctive medications? So in the U.S., guidelines are quite different. It could really depend from state to state. It can also depend from facility to facility, what they have authorized that technologist to do. A facility can incorporate additional training to qualify that technologist to give a specific adjunctive medication. So I have about 40 clinical sites for my students to go through during my program. And when I poll those 40 facilities, I rarely ever get a facility that does anything the same way. Do you know how difficult it is to teach technologists what their role in therapy is when no one does it the same way? So we have to look at a lot of different approaches, what works, doesn't work, what's the gold standard, what's highly recommended, what's suggested. It can become quite difficult, especially when the students are trying to realize what their role is and what their responsibilities are. And they may rotate to one facility and it be very different from the next facility that they rotate to. So we're talking about those amino acids. We're talking about those antiemetics. So sometimes that's strictly going to be a nurse administering those. Sometimes it's going to be the technologist. It depends on your facility. It may even be the physician. So that can be quite different. So I can't tell you, there's one way to do this and there's only one way to do it correctly. We also have to consider space and staff. So if you're just now incorporating a therapy program at your facility, these are things that you have to think about. So these therapies are very time-consuming. Who is going to be with that patient during that therapy? Who is going to monitor the patient and so forth? Required procedure rooms. Do you have the space to accommodate these therapies? May require a dedicated restroom even. Do you have a room that has that possibility? Because remember with lutetium PSMA, 45% of that dose is going to be excreted in the urine in the first 6 hours, the time that that patient is with you. So you're going to have to be able to be prepared for that. And of course, just the staff to handle these therapies. So the Society of Nuclear Medicine and Molecular Imaging has some resources for technologists, and I just wanted to mention this. So when you go to the website, there's actually something called Therapy Central, and there's lots of resources on there, and they're broken into categories, and there's actually a whole section of resources for technologists strictly on radiopharmaceutical therapy. And within that toolkit is something called a checklist. And it's quite extensive, and I'm not going to talk about everything on the checklist, but if you're starting to incorporate a therapy program at your facility, it's something that you may actually want to check out. And within that checklist, and it's split into categories, the first component on the checklist is hospital or clinical preparation. And then there's several items there that would go from things that the clinical site would actually coordinate all the way from coding and reimbursement to referral sources. The next component on the checklist is department preparation. So how do you prepare your department? And within that checklist includes several items on radiation safety, dedicated staffing needs during the therapy. Also underneath department preparation is equipment and supplies and the space. What are the space requirements that your facility would actually need to have the ideal therapy center? The next item is a continued list of department preparation, and you'll see imaging procedures is listed there. Scheduling and appointments is also listed there with several items to be considered for the person who is actually scheduling these therapies for you. The next subcategory on the checklist is faculty and staff preparation. And you'll see on here physician training, technologist training, and nurse training. You'll also see on here some of these overlap. There may be more than one person who takes care of these. Dose administration can be, of course, the physician in training, the user who is supposed to be authorized to do that treatment. As far as the technologist goes, the technologist may actually administer the treatment in the U.S. underneath the supervision of an authorized user. So that person would need to be in the room, but the technologist may administer, or the authorized user may administer. For the nurse in training, they need to be prepared, of course, on the radiation safety issues that was on previous slides. Also on just patient management. those adjunctive medications that they're going to be administering, if a nurse is in charge of that. So this could actually move around a little bit between these categories depending on who you are going to appoint to each of these roles. So there can be some discrepancies here. As I know, my students report back constantly, well, it's this person at this facility, and it's this person at this facility, and it's a combination of people at this facility. So that's constantly changing. There's also a category on the roles and responsibilities of the multidisciplinary team in general. So your medical oncology team, your pharmacist, your radiation safety officer. What role will they play, and to what degree will they be involved in the therapy is something that you have to decide. But this checklist is really good at just making sure that you've checked all the boxes, right? And then the physicist and nurse are also listed there on that multidisciplinary team checkbox list. You'll see the nuclear medicine physician again, and you'll see the nuclear medicine technologist again underneath the multidisciplinary team and the roles and responsibilities. Lastly is patient education and preparation. So how do you prepare these patients? How do you educate them? How do they know how long they're going to be there? What's going to be required of them? All of that needs to be discussed, and who's going to take charge of that in your multidisciplinary team. So the checklist is really phenomenal if you're just starting a therapy program at your facility. And if you already have one, it's really a good resource just to go back and make sure that you've checked all the boxes, that there's not anything that you could change and improve on. So when we look at the future, though, of therapy in general in nuclear medicine, it's early. We're in early phase, right? We had that initial discovery back in the 40s with I-131, but it's taken us several years to get to the point that we're at now. And I really envision that it's going to explode. We're going to see so many new agents on the market, but right now we are still in that new phase. So there's actually projections that by 2030, therapies may actually account for 60% of the nuclear medicine practice in general. So this is going to be a huge change for us. There's over 50 companies working on radiopharmaceutical therapies. It takes a long time to get these agents to market, but they're working on these. So future therapies are likely to be just as complex and involved as the ones that we're seeing most recently across multiple departments. So we're going to have to be team players. And that really comes back to communication amongst those departments. And then the shortage of nurses and technologists is going to necessitate training. Technologists are probably going to be given more roles and responsibilities because of nursing shortages. And then we also have technologist shortages. So what's going to happen in that case when we cannot step up and take control of our own discipline? We are going to have encroachment from other areas who are eager to take our therapies from us. So I just briefly want to show you a few things on workforce shortage, just because I think it ties into this whole process. If we're going to have to figure out who's in charge and what roles and responsibilities, and we're about to see a 60% growth, where are these people going to come from? So just to give you a glimpse here of the U.S., we had 97 nuclear medicine technology programs about a decade ago. So in the past 10 years, we were down 26 programs. 26 programs have closed. They're no longer in existence. Because of that, we're down about 1,500 nuclear medicine technologists over the past 10 years. Rapid decline. But at the same time that we're seeing the decline in technologists and the decline in programs for people to actually attend to become a technologist, we're seeing rapid growth in our field in both molecular imaging and therapy. So you can see there, the projection is not matching up on these slides. So we have to figure out ways to increase our workforce pipeline. The Society of Nuclear Medicine and Molecular Imaging did create a video this year. I'm not going to play it for you. It is on our website just to share with individuals, to let schools share with prospective students on what nuclear medicine is and what the potential is. It's an excellent thing to share to lower level education, through K-12, just to expose these individuals to what could actually be a possibility for them. Also, we've done some things in conjunction with Australia. They also have an excellent brochure as well that they said everyone was welcome to use, just highlighting the different things that you could do with nuclear medicine education. So we need to collaborate because we are a declining population with a rapidly growing field. So these are definitely things that we must consider. So for us in the U.S., with that decline of programs, we're a very expensive program to operate for a relatively small number of graduates. I have 14 students in my program, and I cover 4 states in the U.S., but I am a very expensive program to only have 14 graduates. So typically we are one of the first programs to be looked at to be cut. And we're seeing a lot of that across the world, not just in the U.S. So I just wanted to mention that workforce pipeline issue because it's something that we are going to have to address globally in order to keep up with all the changes that we're seeing in our field. And then with that, I will end and try to keep us on track because I know that you only have one more session that stands between you and the break. Thank you all for having me.